As we get started, I'm Brett Klein with Eisenhower Health, and we are taping this live, so your video and mics are turned off currently. Please use the chat feature to ask any questions as we go along, and then what we'll do is we'll open up at the end for live Q&A as well. So, and this will be, it's being recorded, and as I mentioned, it'll be on our Eisenhower Health YouTube channel. It'll be on the Desert Orthopedic website, and it'll also be on our Eisenhower Health website under Desert Orthopedic. So with that in mind, I'm going to turn it over to Dr. Savin, and we'll get started. Dr. Savin, welcome.
Hello, everybody. I'm going to talk today about shoulder and elbow pain and common causes and current and innovative treatment strategies that we currently have. I do have some disclosures. I'm a consultant for a few companies. And a little bit about me, I was born and raised in Los Angeles and went to college and medical school at UCLA. Then I transitioned to Chicago. I went to the University of Illinois at Chicago and did fellowship in shoulder and elbow surgery at Rush University in Chicago. I've been at Desert Orthopedics since 2017. So the objectives of this talk are a little bit of basics about shoulder and elbow, some mapping the shoulder pain and how do we work up these different types of pain. A little bit about arthroscopy and what arthroscopy can do. Common shoulder problems. Let's talk a little bit about shoulder arthroplasty as well as soft tissue issues of the elbow. So the shoulder is a ball and socket. Imagine you have a golf ball that's flipped to the side, so the golf tee is the socket, and the golf ball is the humeral side. And it's controlled by multiple muscles that give us the ability to rotate the shoulder, lift it up. There's also some ligamentous support that hold the shoulder in place, but the real motor of the shoulder are the big muscles, and the rotator cuff is what allows the big muscles to function. The elbow is a hinge joint. It's actually two joints in one. It's a hinge as well as a pivot joint. So it has three motions, basically flexion, extension, as well as rotation. Multiple muscles are around the elbow, but only a few muscles actually cause action at the elbow. So there's a muscle that bends it, two muscles that bend it, one muscle that extend the elbow, and a few muscles that rotate it. A lot of the muscles that go to the elbow actually control the hand and not the elbow. Sorry. So how do you prevent these injuries? You have to maintain adequate strength and flexibility, good posture and good form, proper warm-up, adequate, appropriate protective gear, and really my main question is don't push through pain. If it doesn't hurt, it usually is fine, but don't push through pain. The muscles of the shoulder, they cause a coordinated contraction that really just holds everything in place. It gives us a wide dynamic range of motion and allows the shoulder to have the most motion in the entire body. This also makes it more prone to injury. So the types of injuries that we can have is sprains, dislocations, strains, overuse injuries, and also fractures. So all sorts of injuries can happen in the shoulder. How do we prevent elbow injuries? Again, same thing. Maintain adequate strength, flexibility, good posture and form. Sorry, let me minimize something right here. There we go. Maintain proper warm-up, so make sure you stretch before, and appropriate protective gear, and again, don't push through pain. So pain in the shoulder could be from multiple areas. So the biceps is the front of the shoulder. That's a major pain generator in the front area. The rotator cuff could cause outside of the shoulder pain. You can also have labral pain, could cause front or back of the shoulder pain, or it can also be related to instability where the shoulder could dislocate. And there's also arthritis, which could be at the clavicle, which is not part of the glenohumeral joints. And superior is the only connection between the clavicle and the rest of the shoulder. And the clavicle cause pain directly on the top of the shoulder. And then you can also have arthritis of the actual shoulder joint, which will cause more global pain around the shoulder. Usually when people refer to pain in the neck area, that's typically not coming from the shoulder, but sometimes clavicle pain can radiate towards the neck, but not into the neck. So we have some pain mapping generators, some pain generator mapping where we've done a lot of tests, and we've actually injected to some poor medical students something that causes a pain, and you inject into certain areas, and you can map out where the pain comes from. Like I said earlier, clavicle pain could be at the top of the shoulder, biceps pain could be at the front, labor pain could be front and back. Arthritis pain and rotator cuff pain could be more global and down the side of the arm. So how do we diagnose this? Well, history is a major component of this. Was there trauma? How long has it been going on for? What other prior treatments or surgeries have you done in the past? And if you had prior surgery, having the operative report can be very helpful. We also have specific exams for each type of muscle, point tenderness, loading different areas to kind of get an idea of where the pain can be coming from. But also we could do injections. All of my injections have a lot of numbing medication. So I can isolate 4 different areas of the shoulder, which could give us a good idea of which area is causing the pain. And if I give you a lidocaine shot into a certain area and that pain goes away, it gives us a good idea that the pain is coming from that area. Current treatments, so rest, ice compression, elevation, anti-inflammatory medications decrease the level of activity, so don't do what is causing the pain. Exercise exercises the rotator cuff to increase the strength. So if you have a torn rotator cuff, some exercises can actually get the remaining muscles stronger and give you a better dynamic use of the shoulder. And injections, they should be diagnostic. When you leave the office, you should have a significant amount of pain reduction. But I do caution overusing steroids. When you look at clinical studies on this, while cortisone can cause some acute benefit, too many shots can increase the re-tear rates or progress the tear. After surgery, sometimes we use steroid shots, which can actually increase the chances of having better range of motion, but does not seem to increase the risk of tearing once the tear is repaired. So if I do shots, we have to make it count. I usually like to do MRIs before I do multiple shots, and I try to avoid cortisone shots. If I'm planning and on doing a rotator cuff repair, as that could increase the chances of failure of the repair. After a repair, I may recommend a cortisone shot if I think that you're getting stiff, which can improve the range of motion and the speed of recovery. Speaking of MRIs, I do like getting MRIs, and I try to recommend not getting an open MRI. The MRI quality is very different. As you see, the picture on the left is a poor quality MRI, and this is an open MRI that could be done locally. Versus a high quality MRI, you can see a lot more detail and have a better idea of what the pathology is. A lot of times, if you've done an open MRI for no reason, I would actually resend for closed MRI because I just cannot make a decision on what kind of surgery would benefit you if you had an open MRI. So now that we did the workup, let's talk about fixing this. So shoulder separations, this is at the top of the shoulder. This is usually from falling, bike riding accidents, skateboarding, or ski or snowboarding accidents. What happens is the shoulder drops down and the clavicle does not actually raise, it just stays where it's supposed to stay. There's ligaments that are torn. You can see on the left side on this x-ray, the bone is sitting a lot higher than the acromion, which is the other part of the shoulder bone, joint. So what happens is you actually tear the ligaments that hold that together. And when these are torn, a lot of times you can actually get these to heal on its own as long as it feels pretty stable. But when it's very hypermobile, sometimes we recommend fixing this. When you get them early enough and it's very unstable, sometimes we could do a direct repair, but usually that requires a more reconstructive surgery. So I usually recommend conservative care for these. I rarely do we need surgical repair, but when it's really high grade, then that's when we do consider surgery. And we do a combination of surgery where we use a suture, cerclage, or some sort of device that holds that that bone down while the ligament heals. And sometimes we augment it with a graft. And this can be done both orthoscopically and open. And it really just depends on what kind of surgery that we're planning on doing. How about a shoulder dislocation? So there's different types of shoulder dislocations. This is common. Usually it's either high energy, or it could be also low energy if you have rotator cuff tearing. And it's a pretty obvious thing when the shoulder is dislocated. You lose the ability to move the arm. It feels like the shoulder area is empty because the shoulder is sitting somewhere else. And on X-ray, we do see it very readily where the shoulder is just not in the right spot. And usually it's an arms forced and external rotation abduction. The arms just basically pulled away, which causes it to pop up. Sometimes it can be a different force causing it to pop inferiorly or out the back. These are usually pretty traumatic and they require you go to the ER to get it reduced. So you'll have deformity. You can't touch the other side. You have severe pain. And usually when you dislocate it, you feel that shoulder pop out. Sometimes there's subluxation events where the shoulder just kind of goes towards the edge and the golf ball doesn't fall off the golf tee. It just kind of gets close to it, then comes right back. Those could still cause a lot of pain. So treatment, we have to get this reduced. So the sooner you get, if you think you have a dislocation, you need an X-ray to get appropriate treatment. And usually it requires some sort of relaxation to put the shoulder back in place. Usually you can treat this conservatively with no strenuous activity for 4 to 6 weeks and mobilization for 1 to 2 weeks with the goal of getting your range of motion back. But the younger you are, the higher, or if there's a rotator cuff tear, it can happen again. And usually the shoulder to put back in, it's popped back in by gentle force, pushing your arm against the wall like they do in movies. That does not work. When we need to repair it, we actually repair the labrum, or we repair any other pathology at hand that led to this, like a rotator cuff tear. Sometimes when you have a massive or very large rotator cuff tear, that's what led to the dislocation, and we can't actually repair it. We actually would have to reconstruct it with a different type of device. How about the biceps tendon? That's the pain in the front of the shoulder, very common. A lot of times this will just rupture on its own and you'll get this deformity that you see on the right side. These are often treated conservatively. The biceps tendon sits underneath the rotator cuff and goes through this little pulley system. And usually if it's inflamed, it could cause that anterior shoulder pain, but also where it attaches in the back of the shoulder can cause a lot of discomfort. Occasionally the pulley that holds it together, the covering, which is the rotator cuff, can get torn, and it causes the biceps tendon to subluxate, which could lead to progressive pain and possibly lead to tearing of the rotator cuff. The way we treat this, I try anti-inflammatory medications. I do a diagnostic injection with cortisone. We do rest and rehab and surgery if we fail conservative care. This is a video of the biceps. You can see this biceps is kind of fraying. It's very inflamed and red. And it's just an angry biceps that is also loose where it starts from. So a tendon like this is not going to do well with conservative care. And this one in particular may actually rupture at some point, but sometimes the pain is so much we don't want to wait for that. So when we treat it with surgery, we actually cut it, take it out of the shoulder, and reattach it down below. It's kind of like the appendix of the shoulder. I just get rid of it in the shoulder, and that works really well. And the recovery, you're in a sling for a month, protecting it for 3 months, and it's highly successful at returning the anterior shoulder, at resolving the shoulder pain. This is a common surgery that's done with a rotator cuff repair. When I do a rotator cuff repair, I'm pretty much always doing this surgery as well. How about clavicle arthritis? So pain in the top of the shoulder is common in weightlifters, difficulty sleeping on the side. What we do for this is usually an add-on procedure. We just shave away the clavicle and give you space so that way the clavicle can have room to move. You see on the left side, there's a lot of arthritis here. There's no space. On the right side, that bone's gone. You have the space where the clavicle used to be. It's often not an isolated procedure. If isolated, we could resume activity as tolerated, but it's not common for us to do that. If combined with other procedures, the rehab is really based on what the most restrictive procedure that was performed. How about the rotator cuff? So it could be a strain or a tear. It's a lateral or outside the shoulder pain, so it's on the side. Night pain, weakness. It can refer down the arm towards the elbow, but it usually does not go past the elbow. So there's rotator cuff tendonitis where the rotator cuff is just inflamed. There's also tears that could happen. It happens from overhead activity, dynamic rotation of the arm at high velocities, such as throwing, poor scapular control when lifting, so you're not putting your body in the right mechanical position. It usually involves individually with a history of impingement or just instability or a lot of overhead use. You all have pain with muscle contraction, especially when we test out individual muscle groups. Tenderness laterally on the tuberosity, which is just the outside of the shoulder. You will have weakness, difficulty using your arm. Complete tear can lead to loss of function, occasionally bruising, and usually we get pain with sleeping. The real thing is you get pain with your arm away from your body, using your arm away from your body. What is impingement syndrome? So sometimes the space where the rotator cuff above the rotator cuff can get tight, and lifting your arm up can cause that tightness to be pinched against another bone. So the way we treat these is RICE or rest ice compression elevation, decrease the level of activity. We do rotator cuff strengthening. We do diagnostic injections. What if there's a tear? So it really depends on what kind of tear there is. There's degenerative or traumatic tears. So is it an acute or chronic? Is it confirmed by MRI? Do you have persistent pain despite whatever treatment we did? And is there pain with sleeping? Rotator cuff tears could be different things. So it could be a massive tear or a small tear. These are treated differently. We can still treat large tears arthroscopically, but there's a limit of what we can do arthroscopically with these tears. So if you feel conservative care, it's a painful shoulder, poor function, can't sleep, and the MRI diagnostic findings correlate with the symptoms, that's when we recommend surgery. And there's used to be doing these open or mini open. Now pretty much they're all done arthroscopically. That's the gold standard. So if your doctor is recommending a shoulder rotator cuff repair, it should be done arthroscopic. What is arthroscopic? It really means joint and to look. That's the Greek origin of the word, but it literally means we're looking inside the joint, the camera. It's similar to kind of seeing a room through a keyhole with a camera versus opening the door completely. It gives us a complete access to the area and it gives us the ability to do a minimally invasive approach to the shoulder. It can be done in multiple joints, the knee, shoulder, elbow, wrist, ankle, and hip. Basically, any major joint can be done. It's technically difficult for people that have not done a lot of them. The basics, you have a camera, you have a light source, and you have the tool that goes inside the shoulder. And you also have working tools for us to actually proceed with the repairs. And these are like the old school techniques that they used to use where they literally would just put their eyes to the camera and look through it. Fortunately, technology has gotten a lot better and the devices are improved where we have the state-of-the-art 4K systems. When we do arthroscopy, we actually have a video of the repair and we send that to the patients afterwards, which they tend to love because they can see exactly what's going on. And we just have a better experience than we did back in the day. So the benefits is a small incision. You get better views, easier recovery, and depending on the surgery, you have a faster recovery. And you can treat a lot more stuff with arthroscopy. The downside is it can be difficult, but that's why we have fellowships. We do fellowships specifically to train us to be great at arthroscopy. It gets swollen, but that goes away pretty quickly. But lastly, not everything can be fixed through a scope. So we have expanding indications, but not everything can be fixed. So this is what we see with arthroscopy. You can see the whole joint. The top, the bottom, the rotator cuff. So we're looking at it from the inside of the joint. We're seeing all the pathology that's noted. And then you can also look at the top of the shoulder and see the rotator cuff from the top side. So we see the inside view and the outside view of the rotator cuff. And when we see the tears, we can. That's supposed to be a video. Let's see if it will play. Nope, no media. So when you have a rotator cuff tear, we could play with it. We could kind of see how well it moves and how well we can repair it. And that gives us the chance to actually reattach it back down to where it was. And we use sutures and anchors to repair the rotator cuff back down into the bone. This is another example of a tear where you can see there's a big hole where the rotator cuff is supposed to be attached, but it's good tendon quality. So I repaired it, and this is how the result of the repair looks, where we reattach it back down to the bone. Sometimes we can't, the tears, even though we heal it, it doesn't heal, or the tear fails. Maybe it's an inadequate repair, poor tissue quality, another injury. So sometimes we have failure of the repair. So this is where we decide what we're going to do next. We can debride it. We could do what we call superior capsular reconstruction, where we reconstruct the top of the shoulder part. There's a balloon spacer, and there's also a shoulder replacement. So long-term outcomes of these repairs, it works really well, but even if it fails, a partial repair can still lead to a successful outcome. The size of the tear and the age do correlate with how well these heal. But we're doing things to make them better. So we have newer generation anchors that vent bone marrow, which technically can have some stem cell or mesenchymal stem cells within it that improve biology. We vent bone marrow into the repair area. We incorporate graft material, And we have goals of improving the environment and local biology to give us a better chance of getting this tendon to heal. We could add structural grafts like the acellular dermal matrix, which is just a human allograft tissue. There's also xenografts, which are animal grafts. There's neuroorthoscopic techniques to incorporate other types of collagen, even collagen from your own body, to reattach it to give us a better chance of tissue incorporation. So this is an MRI of a pretty big tear where the rotator cuff is supposed to be all the way up to the tuberosity over here where my cursor is, and it's sitting all the way at the glenoid. And in this setting, you lose your ability to get a great repair. So sometimes we add a graft. And what that graft is, we repair it first, and we add a patch of collagen right on top of it to give us a better chance of that better chance of that healing. Now, there's also superior capsular reconstruction, where we just reconstruct this whole superior capsule to give us a better fulcrum for rotation. It's a pretty extensive surgery and a long recovery, but when it works great. The issue with these reconstructive surgeries is that there's a chance of failure. And here's one that we did where we had full reconstruction from a tear that was not repairable. And there was a lot of stuff going on, but you can see that patch graft on the right side, which is where we repaired everything, did the supracapsular reconstruction, and we still repaired the rotator cuff around it. The newer technique now is the lower trapezius transfer, where instead of doing a capsular reconstruction, we're actually moving a muscle from the back. And this is arthroscopic assisted, but we still have to open it up in the back to have a better view of the muscle. But we're adding a graft into the shoulder and connecting it to one of your trapezial muscles of the back. And this actually has been working really nicely for a reconstructive option for a massive or failed rotator cuff repair. Another thing that can happen with the rotator cuff is you can get calcific tendinitis. And what happens is you literally get calcium in the tendon, and it looks almost like toothpaste. So when we take it out, we actually just milk it out and try to get that calcium to come out. A lot of times when we're done with this, there's actually a hole in the tendon, and we have to repair it. But this is one of the few things in the shoulder that actually could bring you to the ER, because it is incredibly painful and highly inflammatory and causes a lot of discomfort. So what can we not do arthroscopically? So advanced arthritis, rotator cuff tear orthopathy, which I'll get to soon, most fractures of the shoulder, and specific kinds of rotator cuff tears we cannot really address very well arthroscopically. And especially when we do muscle transfers, part of that cannot be done arthroscopically. And lastly, instability, where you just look at the shoulder and have bone fractures, we sometimes have to open those up and bring in more bone to build up the area. So shoulder arthritis, we talked about this a little bit. So this is where you lose the cartilage on the joint. This is kind of like having a car with a bad tire and wearing down the tire. So the options are you keep driving the tire or you get a new tire. It's age, overuse, trauma, instability, or genetics. A lot of times if you have it on one side, it could be on the other side as well. You have pain, you have stiffness, difficulty with daily activities, and sleep pain again. So this will affect your ability to sleep. Treatment, the same thing. So non-steroidal anti-inflammatory medications, cortisone shots, viscoelastic supplementation, the gel shots. Those are not FDA approved for the shoulder. Sometimes we can get authorization, but that's rare. So it's not commonly done for the shoulder, but historically we have tried it. PRP and stem cells, these are another option. So when you look at the PRP versus stem cell, I usually favor PRP just because of the cost benefit of the PRP seems to be better value. And it's not going to regrow cartilage. The idea is that it's going to hopefully improve the environment and make it less inflammatory. So what about shoulder replacements? We have two different kinds. The anatomic shoulder, which we're reconstructing the normal shoulder joint, and we also have the reverse shoulder replacements. Both work great, and they are for different indications. The standard shoulder is for a good rotator cuff, regular arthritis, where the reverse is for bone loss, glenoid deformity, and rotator cuff tear arthropathy, where your rotator cuff tear is torn so much that we cannot repair it. What do we expect? So we're pretty much mostly doing these as outpatient. You get significant improvement in pain and function. You're in the sling for a month. You get tendon healing for 3 months. We protect it for the first 3 months because we do have to allow some tendons to heal. Golf at 4.5 months, and we don't usually do, the risk of DVT is very low for these as opposed to hips and knees. How long will it last? We're seeing 93 to 95% survival at 10 years. So this does last a long time. We're seeing about 85 at 15 years and about 75 at 20 years. The biggest issue about this data is that this is a newer surgery. We don't have good long-term data. And in the last 10 years, we've gone through 4 generations of implants with improvements at every step. So we think these will last even longer. The most likely scenario with this is that it'll last your whole life. We do have newer technology, so we're planning these now. So we have 3D CT scans, which gives us the ability to see the shoulder and basically virtually do the surgery ahead of time. We have patient-specific guides. We actually have patient-specific implants. We have reconstruction options that allow us to build a bone that are augmented, meaning we could build bone with plastic or metal. We have the reverse, a newer generation reverses. And at some point, we're going to get robotic surgery for this. This is in the works, but it's not. So far, robotic surgery is not approved, but it's currently being designed. Well, if we have really poor bone, we could build up bone with the implants, and it works really well. We have modern implant designs where we have augments for all different kinds of pathology. We have different base plate thicknesses, different clinosphere size or the socket size. We have options for pretty much every pathology out there. And one of the other cool things I told you about preoperative planning, here's an example where I could actually virtually do the surgery and kind of see how everything fits and give me a better idea of what kind of surgery I want to reconstruct the shoulder. And then the newer thing that we're doing is we're actually using augmented reality where I could actually have a HoloLens goggle and allow me to virtually see the plan right in front of me. And the future of this is we're going to be able to use guidance with this. And that's actually something that's currently in the works. And allow us to have a better accuracy with the shoulder. So it's kind of the future of shoulder surgery. Restrictions, once you're recovered, I don't give any restrictions. I let you do whatever you want. Sports usually start 4.5 to 6 months. Get back to tennis, golf, gym activity, pickleball, snow sports, and more, including swimming. So shoulder recommendations in general. So make sure you follow the postoperative instructions. Usually we start with a gentle stretch. We don't strengthen right away because we want the tendons that we repaired to heal. There will be pain, so pain meds will help, but they will not make the pain go away. The ice machine is worth its weight in gold. So there's ice machines that run cold water over the shoulder. The benefit of this is just really makes the recovery a little bit more comfortable. Unfortunately, insurance does not pay for that, but it's available online to buy, or we actually have those at our office too. Stool softeners need to be taken while on narcotics. All right, moving on to the elbow. So the elbow we talked about, it's a complex joint. It has a lot of force goes through it. There's a lot of ligaments and muscles that stabilize the elbow joint. Tennis elbow is probably one of the most common things that we see, as well as golfer's elbow. So tennis elbow is pain on the outside of the elbow, right at the bone tip, and golfer's elbow is on the inside. Now, you don't have to play tennis to get tennis elbow. You don't have to play golf to get golfer's elbow. There's just an overuse injury that specifically using your hand. So tennis elbow, pain over the outside of the elbow. It's where the bone attaches to the bone. There's usually a small tear there. It's found to have an impact on a lot of people, so 1 to 3% of the general population at any time. Most commonly affects men and women 40 to 50 years old, but it could be at any age and any activity level. Pain before, during, and after activity, pain when you press on it, and especially pain when you use your hand. Usually it's overuse, so it's repetitive use, usually wrist and finger motion, so whipping, lifting, carrying, prolonged and rapid activities, so those are sporting activities. How about medial condyle on the inside of the elbow? Similar range group of people that happen, and it's repetitive micro trauma to the common flexor tendon, which is the tendon on the inside of your elbow. Mechanism of injury, so throwing in baseball, racket or tennis sports, swimming, backstrokes, hitting a golf ball. So usually when these involve racket sports. They're people that are pretty wristy. Pain on the inside of the arm, pain on palpation, and you have pain with rotation as well as pushing your hand to your face or gripping. So this is an overload. So you have some sort of a tear. The tendon tries to heal, but it never gets a chance to heal. You continue to overuse it. You get weakness and imbalance, and you get more tension overload. So it's kind of a cycle of events that happens that lead to this tear getting worse. And one of the biggest issues, we never give it a chance to heal, and it doesn't heal very fast. When we look at it, it just looks like disorganized tissue. It's disease scar tissue. And we look at it in the microscope, it's not inflammatory, it's just disorganized tissue. So, and it's an inadequate attempt of a repair, almost like avascular necrosis, which is where the tissue just starts kind of eating itself up. So how do we treat these? So there's lots of stuff you could do. So changing your stroke or getting better lessons or better equipment, stretching, anti-inflammatory pills. There's a brace called the counterforce brace that can help. Soft tissue modalities can helpful, as well as rest. If you do nothing and you rest it, it will usually go away, but most people are not very good at resting the elbow. So other equipment issues for golf, is it very stiff? Do you have a soft padded grip? Is there a technique issue? Do you have a good proper swing? Is the racket well balanced? Is the head size okay? Is the length correct? Is there good flexibility? Is it too stiff? Is there a non-padded grip? Do you hit the shock absorbers? Could also help with this. So for golf, I usually try to say avoid hitting off mats, hit off the grass, proper weight shift, well padded and larger grips, flexible shafts with no flicking of the wrist. Treatments, so I don't recommend playing through pain. Rest and ice, non-steroidal, anti-inflammatory medications, stretching before, during, and after. Topical creams and bracing. Moving on to cortisone shots, that is an option, but I tend not to do cortisone shots for this. I do like platelet-rich plasma. I also think physical therapy can be helpful. I do give everybody an exercise sheet that gives us an opportunity to stretch it and strengthen the elbow muscles or the muscles that are related to tennis elbow and golfer's elbow. The counterforce brace, it just really allows you to protect the arm and allows you to not cause further damage when you wear the brace. So I usually recommend wearing these while you are still rehabbing the elbow. Cortisone shots, there's some studies on this, a lot of studies that are coming out more recently that overall there's using cortisone injections to have a significant long-term negative impact on the tendon cells. What we're seeing more and more is that cortisone shots can lead to worse outcomes and longer time until recovery. It does get rid of the pain really quickly, but over long term, it's not a good option. And when we compare it to other modalities, cortisone injections tend to have worse clinical outcomes. So it's a comfort versus cure game. So we can make you feel better right away with the cortisone shots, but it's going to make the cure a lot harder to obtain. So what about PRP? PRP is where you take your own blood, concentrate the healing factors, and inject that directly into the tendon. This does work really well for getting this tendon to actually heal and stimulates the healing response. We look at studies on this. So PRP, we take about 80 cc's of blood and we concentrate it down to about 4 or 5 cc's. So it's a very highly concentrated product. We look at studies, PRP is favored. It's favored over placebo or controls. So it does work pretty well. So if nothing works, there's always surgery. And the surgery is simple. You get rid of the bad stuff, leave the good stuff, and then we repair the tendon back down to the bone and make sure there's nothing else going on inside the elbow. And again, this diseased tendon, we clean it, we debride the bone, and we repair it, and it actually works really well. Post-op, we get ADLs and functional use of the arm at 1 week, meaning brushing your teeth, doing your hair, getting dressed. Easy sports, 6 to 8 weeks, and play to win 4 to 6 months. So it takes time, but this is a very successful surgery with a high chance of getting back to your prior activity. So my final thoughts on epicondylitis, don't push through it. Rehab and rest are first-line treatments. Very limited use for cortisone shots. Consider biologic injections. Be patient. I usually wait about 4 to 6 months before we recommend surgery, and surgery is an option when nothing else works. Biceps tears, these are acute tears of the distal biceps of the elbow. This is not the same as the proximal biceps. Very common, mostly in males. And what happens is you're lifting something heavy or something shifts and you tear the tendon off the bone. This is something that actually we'd like to fix more acutely. You'll get bruising, you'll get this Popeye deformity, and usually you can tell that it came from the elbow. And you can see a gross deformity. If left alone, it'll always be like that. But the main thing is we recommend fix this because you get functional loss of your arm. MRIs can show us these tears and tell us whether or not it's repairable. And we rarely treat without surgery. We reattach the torn tendon back down to the bone using anchors. So we basically just make a hole in the bone where it came from, and we just shuttle the tendon back into the bone. And this works really well and has a very high success rate. Rehab is very slow. So we do range of motion for the first 6 weeks. After 6 weeks, we do a more aggressive rehabilitation. At 12 weeks, we start strengthening. It's a slow recovery, but it does work. And full recovery is usually close to 6 months, when I say you can lift whatever you want. Triceps is a very similar thing. It's a rare injury, but usually males and bodybuilders, it's a load that is unexpected, where such as you're bench pressing or lifting heavy weights, you're pushing away from your body, and the load shifts and you get an unexpected increased load. I've heard stories of pushing fridges or pushing a couch and causing this type of pain and a tear. I try not, this could happen in steroids. People that take anabolic steroids or just systemic steroids, as well as systemic illness. The tendon usually feel a pop, you get bruising, you get swelling, and you have a very palpable defect, and you have weakness with straightening your arm. And MRI confirms the pathology. And we just, same thing in the biceps, we just reattach it back down to the bone using sutures and anchors. The rehab's the same, range of motion for 6 weeks. 6 to 12 weeks, we do more aggressive range of motion, as well as shorter rehabilitation. And strengthening does not start until 3 months. Olecranon bursitis, I see this a lot out here. This is just swelling on the back of the elbow. There's infectious type and non-infectious type. This could be from trauma where you hit it and you get swelling. It could be overuse, it could be gout, but it could also be from an insect bite or cut or some sort of infection that got to this area. Our body's not very good at clearing infections in this area because the blood supply is pretty poor. So if you get some sort of injury there, infections can happen. It's pretty obvious when there's an infection, you get cellulitis and a lot more pain. When it's just the olecranon bursitis from just fluid collection, it usually is not very painful. So there's difference in what these look like when it's infected or not. I usually, for non-infected types, I try cold compression, full time for 4 weeks. I give you a compression sleeve, non-steroidal anti-inflammatory medications, especially Voltaren gel. I try not to aspirate these because that can lead to an infection. If it's recurrent or sinus tract forms, we do a surgery to wash it out and clear up that sinus tract. If it's infected, then usually surgery is necessary for this. Last thing, so ulnar nerve. So there's carpal tunnel at the wrist, and there's ulnar neuritis at the elbow. These are areas where the nerve can be compressed along the inside of your elbow. And this will lead to numbness to your small finger and your ring finger of your hand. It's a very superficial position at the elbow. It's the funny bone. You have pressure on this area from bracing or resting on a hard surface. It's the second most common entrapment neuropathy or compression neuropathy of the arm. So carpal tunnel is first, cubital tunnel is second. The nerve goes through these different tight areas that can cause compression, and also does this 90-degree turn, which can lead to increased compression. So people that have their hand to the ear a lot, so on their phone a lot, can have increased numbness. People that sleep with their arm bent, repetitive activities, as well as this nerve can occasionally subluxate, meaning it pops out of its groove. It does not mean you need surgery, but it's more prone to getting cubital tunnel. This is an example of somebody where that nerve just pops in and out, as you can see on the bottom. Doesn't mean you need surgery, it's just something that happens sometimes. The numbness that you experience is on those two fingers that are blue. It's just a very common presentation. The rest of the fingers are from carpal tunnel. These ones are from this nerve. I tried to avoid compression for this. I try to recommend you sleep with your arms straight, so you can do nerve glides. We could try non-steroidal anti-inflammatory medications. A nerve test can confirm the pathology. Occasionally, we'll do a cortisone shot around the nerve. And when the nerve does not calm down, we do a surgery to release it. Just like carpal tunnel, we just do a small incision and we release the nerve and we leave it where it lies. We start early range of motion afterwards. It slinks for comfort. Full motion, usually by 2 weeks. If not, we do therapy. And no restrictions after 6 weeks. And that's it. That's everything shoulder and elbow outside of trauma. I guess we'll open up to questions.
All right. Great. Thank you, Dr. Savin. That was a lot of content, which is fabulous, as always. Let's go ahead and open up the conversation. So if anyone has a question you would like to ask the doctor, please just unmute yourself and feel free to ask the question or put it in the chat if you would like me to relay it to the doctor. I know one thing will get the conversation started. I know because I had a clavicle break from cycling and shoulder issues. So the question is, if you've let it heal and it's gone through its process, does your other side of the body, like say you have your left side that is the issue, and so during the process of healing, how do you combat or how do you work with your other side of the body, which is now compensating for that? What is that process, do you think?
Yeah, so when you have an injury on one side, or if you have surgery on one side, your arm's in a sling, you're really gonna have to use your other side for pretty much everything. And sometimes you get some increasing pain, especially if there's prior pathology. So I usually recommend, proper form. Don't overuse the arm. Protect it the best you can. But if we need to do a steroid shot, we can on the other side to help alleviate the pain. Sometimes this really requires some activity modification and not overdoing it because you will overuse the arm. As the other side starts getting better, that tends to go away because you eventually end up with 2 functional arms.
Got it. Thank you. All right, let's take some questions. Feel free to unmute. Give it a few seconds here. Oh, there's a question in the chat. It says, can you partially tear a bicep?
Yeah, so we'll talk both the shoulder and the elbow. Yes, you could partially tear it on both sides. The shoulder has 2 biceps tendon that attach to different areas. One of them does not tear, but on the video that I showed you, there was a partially torn biceps of the shoulder where it's starting to kind of unravel. So you can partially tear it, but it does not retract. At the elbow, you can partially tear, and that can be very painful at the elbow. This is especially with rotational use like supination, where you bring your palm up, you can really feel it in the elbow if you have a partial tear. These partial tears sometimes can lead to a complete tear.
All right, thank you. All right, feel free additional questions, and again, feel free to unmute and or put it in the chat, and we'll get them answered for you. All right. With that, doctor, unless you have any final comments or any other questions, we're good. What do you think?
If that's it.
All right. Well, thank you all, and thank you, Dr. Savin, for being here and doing this for us. And we'll be back in touch soon with additional conversation.